Hello, I want to welcome everybody to another Let's Talk Clot session. This is a very special one. It's on the role of injectable non-heparin anticoagulants and really provoked by VIT, vaccine-induced immune thrombocytopenia and thrombosis. I'm Beverley Hunt. I'm one of the medical directors of Thrombosis UK and actually the founder. It's great to be here. The first speaker is just perfect for the task of talking about the clinical aspects of non-heparin anticoagulants. So Will Lester is a consultant at Queen Elizabeth Hospital, Birmingham, and also at Birmingham Women's Hospital. He majors in thrombosis and hemostasis, obstetric hematology and immunohematology, and he's vice chair of the hemostasis and thrombosis task force for the British Society of Hematology guidelines, and he's been a major force in VIT in the UK, being a core member of the expert hematology panel. So without much ado, let's hear what he has to say. Thank you.
Well, thank you, Thrombosis UK, Joe and Beverley, for the invite to speak today. Now, I'm going to be talking about non-heparin injectable anticoagulants and the clinical aspects of this, because I'm going to leave the laboratory aspects to Steve. And I thought, well, what might be useful is to look at what these non-heparin anticoagulants are, how they work, and when would we need to use them, and maybe just mentioning how we monitor them, but not to go in any greater detail than that. These are my declarations. So let's start with a case. So this lady, 70-year-old with a history of multiple PEs who's been on long-term warfarin and requires a colonoscopy. So we normally stop anticoagulants for this in case they need a polypectomy. So warfarin stopped for 5 days, and because of the frequent VT events, there's some prophylactic low molecular heparin bridging while the warfarin stopped. But 5 days after the colonoscopy, when there's an overlap between restarting the warfarin and the keeping going with the low molecular heparin prophylaxis, this lady rings the anticoagulant clinic saying, yesterday's injection site is really painful. So we bring her in, and she's got this large area on the skin, which is almost necrotic at the yesterday's injection site. And when we take bloods, we find that the platelet count is low. What's going on here is quite a rare reaction. It's called cutaneous HIT, or heparin-induced thrombocytopenia. It's typically not seen with prophylactic doses of low molecular heparin, but this is one of the rare cases. And so this is a form of heparin-induced thrombocytopenia, which is one of the main indications, I guess, for a non-heparin anticoagulant. A little bit about HIT, or heparin-induced thrombocytopenia. It's a sort of perversion of a natural physiological response to bacteria. So we have this. We make this protein called platelet factor 4, and it can bind onto the negatively charged lipopolysaccharides of bacteria, and it sort of enhances the B cell response, and you can make transient rapid IgG antibodies, which then bind the combination of the platelet factor 4 and the target bacteria to basically clear them. HIT is a sort of aberrance of this, because instead of platelet factor 4 binding to the bug that you want to eradicate, it's binding to heparin, and then that combination develops the formation of an antibody, a PF4 antibody, which then can bind to the PF4 heparin combination, which then unfortunately activates platelets, causing degranulation, and it's intensely pro-thrombotic. And who's at risk of HIT? Well, those people exposed to high doses of unfractionated heparin, repeated or prolonged exposure to heparin, renal dialysis, cardiac surgery and orthopedic surgery, and certain people with genetic susceptibilities from their platelet receptors. The diagnosis can be quite tricky because it's quite rare to find it these days outside of the context of ITU. And on ITU, patients often have multiple other issues going on which can cause low platelets. So it can be a difficult judgment call. We do have something called a 4T score, but I don't find it that helpful for ITU patients myself. But the treatment, when you suspect it, because it's so prothrombotic, is withdrawal of heparin and use an alternative anticoagulant. And that would be Gatroban, fondaparinux, dinaparoid, and more so these days, DOACs, although not necessarily right at the beginning when the diagnosis is first made. And these are the drugs that we're going to look at in a bit more detail. Just a bit about re-exposure risk, though. Actually, it tends to be this immunological reaction that HIT mimics tends to be relatively short-lived, usually lasting about 90 to 100 days. So if you re-expose people to heparin beyond 100 days after the initial HIT diagnosis, often there isn't a recurrence. Although if you do re-expose people to heparin shortly after the diagnosis of HIT, you can get an awful anaphylactoid or DIC-like reaction because of the persisting presence of these PF4 heparin antibodies. And we've subsequently recognized something beyond HIT. It's a bit like HIT, but it's a spontaneous or autoimmune HIT where patients can develop these PF4 antibodies without even having exposure to heparin at all. And then we have VIT. And VIT is, again, a similarity to HIT and more so to spontaneous or autoimmune HIT in that they are PF4 antibodies, but they're not heparin dependent. This is my timeline for VIT, just for reference. So when this is a very early iteration of the guidelines that we produced and put onto the BSH website about recognition and diagnosis treatment of suspected VIT, and that included non-heparin anticoagulants. And that's because we were quite concerned that this syndrome mimicked HIT so closely that maybe heparin could exacerbate things. But I'll say now, actually, there's no evidence that heparin exacerbates VIT, and there is some in vitro evidence that it might even reverse some of the platelet activation caused by the PF4 antibodies in these patients. But it's a little bit late for us in the UK to be looking at trials in this regard because we're not seeing cases anymore. But my personal feeling is heparin probably isn't an issue here. But the current rule of thumb is we use a non-heparin anticoagulant, and we were quite keen on using Gatroban and fondaparinux in our sickest patients. And a lot of these sick patients had low platelets and they had secondary bleeding when they got cerebral vein thrombosis. We're very concerned about the toxicity of anticoagulation. And so we're using frailty doses of both of those non-heparin drugs. DOACs were also used, but generally not in these sort of susceptible patients at presentation. But let's look a little bit at the drugs and how they work and where they come from. So unfractionated heparin. It's a long chain molecule, a glycosaminoglycan. It's unpredictable in terms of its bioavailability, but if you chop it into little pieces, you then get low molecular weight heparin. And that's all low molecular heparin is, a chopped up version of unfractionated heparin. We have a century of experience with heparin. It is physiological, as we'll get to in a second. There were no drug interactions of note, and that's one of its greatest properties. It's got a short half-life, which is really handy. As a sort of an antidote, a drug called protamine, although it's not very effective with low molecular weight heparin. It's safe in pregnancy, which is a great advantage, and there's loads of high-quality trial data. But heparin is manufactured from porcine intestine, and most of the porcine products come from China. And I guess this touches on another reason we might use non-heparin parental anticoagulants. NICE guidance NG89 says be aware that heparins are of animal origin, and this may be of concern to some people. And it says see religion or belief, a practical guide. I did click on that. It's a defunct document that doesn't mention heparin at all, so I wouldn't bother. Discuss the alternatives with people who have concerns about using animal products. The wording is everything. It doesn't say we have to absolutely inform everyone. It just says if someone's concerned, you need to talk about it. We did an audit a while ago locally. We found that 10% of patients were aware that heparins were of animal origin. Of those who were informed, 10% said they would have some concerns about that. I was quite surprised actually that there was that many that actually knew, because we find a similar level of knowledge amongst clinicians, to be honest. But there are issues to to bear in mind here, and that's that over 1,000 medications contain porcine or beef-derived or stearic acid or alcohol in the manufacturing process, lots of things that people wouldn't necessarily care to eat. There is an issue about the education of healthcare professionals and an issue about the time and resources. If we had to sit there going through every single drug and every component of every drug, I don't think we get anything done. And there's no good research on the impact of a blanket policy where we did have to inform everyone of every content of every drug either. If we look at different sort of belief systems, then generally speaking, the sanctity of life does overrule any concerns about the administration of porcine material in terms of religious texts that talk about not eating pork. This is obviously not exactly doing that. But the sanctity of life generally overrides these things. So religious leaders are aware of this. And we have to accept that heparin is a life-saving product. The Vegetarian Society do say that they would prefer information about the origin of drugs to be available to all patients. So let's get back to heparin, unfractionated, chopped in small pieces. Is there a non-animal product option? So yes, there is, fondaparinux. So fondaparinux is a synthetic drug. It's a pentasaccharide, and it represents the 5 most active sort of units of the heparin molecule. And it's also given by subcutaneous injection. It works in a very similar way, as we'll see in a moment, but it is synthetic. So we can compare fondaparinux and low molecular heparin as being similar. Both bind to a natural anticoagulant called antithrombin, which then enhances the action of antithrombin about 1,000-fold to inhibit 10A. You'll be familiar with drugs like rivaroxaban, apixaban, and edoxaban, which are direct inhibitors of 10A, but the heparins are indirect inhibitors through the action of antithrombin. Unfractionated heparin also stimulates antithrombin as a cofactor to inhibit thrombin as well. So it has slightly different sort of point of action on fractionated versus low molecular heparin, although low molecular heparin also has a minor effect here as well. And if we were to compare that to an oral, dabigatran is a direct inhibitor of thrombin, but we're talking about injectables today. So that's a little bit about the mechanisms involved. Essentially, they inhibit points in the pathway of the coagulation cascade that ultimately reduce the formation of fibrin and the formation of clot. Some direct inhibitors, some indirect. So why hasn't fondaparinux caught on? If it works a bit like heparin and it's not an animal product, why don't we use it all for everybody? Well, probably the most important reason is it's expensive. So a prophylactic dose is £6.28, whereas a dose of enoxaparin is about 70p. And you say, well, that's not a big difference. If you times that by hundreds of thousands of doses every day, it becomes a huge difference, and it could bankrupt the NHS overnight. A therapeutic dose is also expensive. It's about £12 as opposed to about £3 to £4 for heparin. It's mostly renally excreted, so it does have a long half-life. So I think that is a bit of a disadvantage compared to unfractionated heparin, which is excreted, half-life about 1 to 2 hours, versus low molecular heparin, which has a half-life of around 4+ hours. And there's no antidote, although I don't think that's a big issue, to be honest. When would I use fondaparinux? Well, I'd certainly use it in the initial treatment of hit and bit patients who are not dialysis dependent. As I say, it's renally excreted, so it's not ideal in that context. Patients with venous thrombosis who have failed low molecular heparin, so perhaps a cancer patient who's already on a BD dose of low molecular heparin and still gets a breakthrough clot, we have found in cases like this, sometimes a switch to fondaparinux with the addition of, say, an antiplatelet agent like aspirin can hold a patient in terms of thrombosis breakthrough. It's also a lot nicer to have injection into you. It's a lot less stinging. It's much more pleasant. So if someone's on long-term treatment, they certainly appreciate the difference there. I think it's quite useful for patients who do refuse low molecular heparin because it has an animal origin. It's not, well, outside of pregnancy, it's pretty straightforward. In pregnancy, it is a small molecule that does cross the placenta, but it's not known to cause harm. So we have used fondaparinux in pregnancy where it's been refused, or there's an allergy to low molecular heparin. It is licensed for thrombophlebitis with 2.5 milligrams for 6 weeks. And it is handy when someone has an allergic reaction to low molecular heparin. Not all allergic reactions are HIT. It's not normally it isn't HIT, actually, like my first case. Normally it's just an allergic reaction. And in those cases, often fondaparinux is tolerated. Can you measure it? Yes, you can use an anti-10A based assay, a bit like low molecular heparin, and it's converted to a drug level when you get the result. But it's virtually never needed, to be honest. We have done it before when we used it in some dialysis patients when we couldn't get hold of dinaparoid, but it's not a test that's often required. But if you need it, you can do it. So dinaparoid, I've briefly mentioned this. This is an alternative low molecular heparin like drug, which has very little structural similarity to low molecular heparin. So you can use it in patients with HIT, but it is also derived from porcine mucosa. So it doesn't get around the issue of whether that's been refused because it's of animal origin. It does have a long half-life, which I don't think is ideal. It can be given as an IV infusion for therapeutic purposes, although it is quite a faff and it's a fiddle where you get a bolus and then various step-down doses. So it's hard work, I'll be honest with you. But you can give it subcutaneously as well, BD. There have been supply issues, so it's been difficult for us to get hold of it from time to time, and it is expensive. And it rarely needs monitoring, but if you're giving therapeutic doses over many days in ITU, I guess it's an option to do 10A monitoring if you want to. But let's get on to the next set of drugs. These are the thrombin inhibitors, and you'll be familiar with the use of leeches medicinally. Leeches produce this protein, a natural anticoagulant, which is sort of similar to something called hiridin. It's quite handy for the leech because they want to keep sucking your blood. They don't want to have to suck up the clots. They want a nice fresh flow. And as we've often done in medicine, we've taken something from the plant or animal kingdom and turned it into a drug. A little bit complicated, but these are inhibitors of thrombin. And I've mentioned earlier that unfractionated heparin and to a lesser extent low molecular heparin through antithrombin can be an indirect inhibitor, but we have some direct thrombin inhibitors, and hiridin was sort of altered for the purposes of therapeutics to a drug called lepiridin, and that's a strong irreversible inhibitor of thrombin. So it's a leech-derived, I guess, leech-derived medicine, but it's pretty toxic, massive high risk of major bleeding. I never liked that drug. I virtually never used it, and now none of us use it, thankfully. The drugs that we do use, and they're given parenterally and are oral, are gatroban, as I mentioned, and bivalirudin. Very similar properties, similar benefits, similar risk. But I'm going to focus mainly on our gatroban because it is licensed for HIT. Just as an aside, dabigatran is also a direct inhibitor of thrombin, but it's an oral and we're not talking about oral. So we'll focus on our gatroban here. So what can I tell you about our gatroban? It's given as an IV infusion. It has a very short half-life, about an hour or so, which is a great advantage if you're sick on ITU when you need to switch it on and off. And it's great for patients with renal failure because it doesn't tend to accumulate particularly. There is a frailty ITU dose regime, which is quite handy, and that's the one we did often use in VIT, although not exclusively. And but it must be monitored and titrated, unfortunately. And the only easy access test that most laboratories have in the country is the APTT. So it's very much like the monitoring of unfractionated heparin with an APTT, although it's supposed to be checked every 2 hours till you get into range. But the APT is absolutely rubbish, and I think Steve is going to touch on that. I'm not going to say anything more, other than there are specific assays, but they really need to be introduced into more laboratories. So I'm going to finish with a summary. So non-heparin injectable or parental anticoagulants include argatroban. It's a direct thrombin inhibitor. It's given as an IV infusion. It requires regular monitoring, ideally not with an APTT, but that's all most people have. Fondaparinux, it's an indirect 10A inhibitor. It's a synthetic mimic of low molecular heparin, and it's given subcutaneously. And dinaparoid can be given either intravenously or subcut. It's also animal origin, so isn't an advantage in that regard. But they are all expensive in comparison to heparin, but they are useful for HIT/FIT skin reactions to low molecular heparin, people who refuse animal origin products other than dinaparoid, obviously, which is animal origin, and for, in some cases, it's certainly my experience, for failures of heparin. And with that, I will hand over to Steve. And thank you for your attention.
Well, that was a fantastic summary of where we are. And so I'd like to introduce Steve to you if you don't know him already. We are really blessed in the UK with some fantastic experts, and Steve is one of them. So Steve Kitchen has been scientific director for UK NECWAS for blood coagulation for many years now, and his role is really important. They do work with the World Health Organization in establishing international standards for all sorts of coagulation proteins, anticoagulants. He also works with the World Federation of Haemophilia, doing much the same. He's also the head scientist at Sheffield Hemostasis and Thrombosis Labs, and he's been there for 25 years, and he's really active in the scientific subcommittees of the International Society of Thrombosis and Hemostasis. There is no one better to talk about monitoring these non-heparin anticoagulants. Steve, over to you.
Wow. Thank you, Beverley, for a very, very kind introduction. It's absolutely a pleasure to take part. I think Thrombosis UK put together a great program. Really good. I hope participants will be able to have already enjoyed some, and it looks like a really good session on VIT next week. I shall certainly try and attend that. Okay, back to today. So I will share my screen, hopefully. With luck, that looks like you should now see it. Well, okay, so we've had the clinical picture nicely from Dr. Lester. So I think my brief was to concentrate on lab perspective monitoring non-heparin anticoagulants. Well, that's a big list of non-heparin anticoagulants. I will make a few comments on some of the oral non-heparin anticoagulants, a little bit of comments on warfarin and on DOACs, not much. I want to focus and begin with what I think we're mainly discussing just now. Let's say the parental anticoagulants, starting with argatroban. I was very pleased to see one line on Dr. Lester's slide also saying why APTT is useless rubbish. I hope to convince you of that. Its only advantage is it's cheap and available, and I don't think that's good enough, and I'll explain why I would say that. So argatroban monitoring. So we've got a problem, I think. We've got the summary of product characteristics, and we've got recommendations from BCSH. I was involved in constructing those. We've got other recommendations available to us, and the SMPC recommends APTT, and to use a ratio of patient APTT divided by the patient's baseline APTT, the baseline before therapy. It recommends we use that ratio and that we aim for a target of 1.5 to 3, so 1.5 to 3 times prolonged over the patient's baseline. It also goes on to say that we shouldn't exceed 100 seconds because of the bleeding risk. So I think there are a number of issues with that. And if you look at the clinical trial that was used to let's say, support that recommendation, I think one of the problems is that the trial permitted recruitment of cases who had a baseline APTT anywhere up to a ratio of 2 compared to the average normal. So these were patients with grossly prolonged APTT. And of course, these are very sick patients. It's not a surprise that this kind of case on ITU would sometimes have prolonged APTTs. So you could have at that time patients who were already inside the target before any drug was administered. So there's already a problem, I think. No drug on board in the range. And of course, those of you who work in labs, and many of you will be aware that APTT is available in many different forms, lots of different reagents, and in any setting, whether it be heparin or factor deficiency, or argatroban in any setting, there is always a range of response, a range of sensitivities. Different versions of APTT respond differently. And I've tried to show that in this slide. This is a study by Susan Guy in my lab some years ago now, it's 2015. So this story's, I think, been in the literature for some time. What you've got in the chart here, some APTT ratios by four different reagents. They're not identical. You can see they're different. And if you look in the table, if we ask the question, what's the drug concentration required to cause a ratio of 1.5 up to 3, that's shown here. So for this reagent, between 0.55 and 2.5. But from other reagents, close to twice as high, certainly here. So quite a range. These data are based on adding drug to plasma, spiking the drug into normal plasma. And it's become clear, including some of the work that Susan did in this study, that this does not mimic properly real patient samples. So what about real patient samples? So these are more data again from that same article. And so I'll just talk you through this slide. Each point on here is an individual real patient sample. The total 15 or so patients, so multiple samples from these 15 patients. And we've got APTTs with 2 different reagents. Synthesil, the green boxes, and this is a reagent used in about half of UK laboratories. And then in the purple crosses, Actin-FS, most of the other half of UK laboratories use this one. You can see there's a difference. The scatter of purple points are above, green below. Different results according to the reagent in use. So that's confirmed in real patient samples. The solid black lines here, 1.5, 3.0. So this is the therapeutic range by APTT ratio. The red lines are the approximate limits of the therapeutic range if we use argatroban concentration. I'll come back to the evidence to support the position of these lines in a moment. So just for now, we're talking about somewhere between 0.3, 0.4 micrograms per mil at the lower end, up to around 1.2, 1.3 at the upper limit. So if we look in this box here, these are a series of samples, APTT ratios in the range between 1.5 and 3, apparently therapeutic, and yet very low level of drug present. And in some cases, essentially no drug at all. There are other reasons why the APTT is prolonged. It's not safe to monitor those cases with this APTT, completely misleading. These patients based on APTT are underdosed in relation to drug with a risk of new thrombosis. And then here are patients who are inside the target by drug. They've got the right amount of drug on board, and yet despite that, their APTT ratio is still very short. And the reason for this is there are other reasons why this APTT is very short. These patients have very high levels of factor VIII, and so that influences the APT ratio whilst they're sick. So these patients, adequate levels of drug, despite an indication from APTT that would lead to an increase in dose. And with that carries a bleeding risk. So I think, and these are not a few patients, there's a significant proportion in these boxes. It's really not a good test. And if you look here at the relationship on average between APTT ratio and drug level, it's pretty flat. There's no clear relationship that you might expect if the APTT were appropriately responsive to changes in argatroban levels. So it really is a bad test. And now, of course, we come up to, let's say, the more recent period, last 18 months, patients with COVID, increased use of argatroban for the reasons that Dr. Lester's mentioned. And so now we've got even a group with very marked elevation in factor VIII. Those of you in the lab seeing APTTs, you will have noticed that we've seen shorter APTTs in COVID than perhaps we've seen in anything else outside of maybe emicizumab levels in hemophilia. So very, very short, very high levels of factor VIII. It means the APTT is flawed. There's also a plateau effect. The APTT is insensitive to high levels. I didn't bring a slide, but I can recall a case in our center. the sample was collected inappropriately through the line, contaminated with drug, and the level of drug was about 10 times the upper limit of therapeutic target, 10 times too much drug in the sample. Despite that, the APTT ratio would clot. It was only about 4.5. So it was above the range, but not by very much. That's not a situation you would see in such a massive overdose of heparin, for instance. The APTT would simply not clot. So it's another, I think, nail in the coffin for APTT. There is an extremely poor correlation between APTT and argatroban. So in a recent study, again, that Susan did in our laboratory, a little bit more recent, 2017, these correlation coefficients are really, really low for 6 different versions of APTT. It's effectively a flat line because the APTT is so non-specific for argatroban. And also a further problem, depends on the base, depends on the reagent, but there are some reagents for which 100 seconds would sit inside the target of 3 times the baseline. So I think there are all sorts of problems with it. So what is our alternative? Well, there are argatroban assays available. The dilemma is that there isn't, let's say, a full consensus on what the therapeutic range should be. And a number of the articles have come to a conclusion about what level to aim for in drug concentration, using working backwards from APTT. Start with APTT 1.5 to 3, put drug into sample and normal plasma, and then work out what's equivalent. I think that's a bad way to do it. That can be misleading. Better, of course, is to look at clinical outcomes. And there's one publication, at least, that's effectively a clinical study, and they've been using this range, 0.4 to 1.2. And I'll show you the information in that small study in a moment. So we don't have large studies, number of different ranges, but there is some agreement, let's say, between the different studies. So this is the case that looked at the study that looked at, let's say, outcomes to some extent. It's only small. They had 68 cases monitored by APTT and 75 cases monitored by anti-2A. It was in a lab in the States who'd made the change from APTT to argatroban assay. They used a chromogenic assay, results interchangeable with the dilute thrombin time assay that's more widely available in the UK. I'll come back to that point in a moment. Again, this was the target that they used for therapy. And they looked at these two, monitored effectively half the cases by APTT, dose adjustments based on APTT, and the other half monitored and dose adjusted according to drug concentration. And because of this problem of short APTTs and so on, it was in their center, they reported a much higher level of drug required for the APTT to reach the target on average. So the median concentration required was 2 micrograms per kg per minute in the APTT group, and that was about 3 times higher than the amount of drug required in the group monitored by anti-2A. So the budget managers would be pleased by that. Is it safe? Well, they concluded it was. They had three thrombotic events in the APTT group, 2 in the anti-2A. Of course, these are really, really small numbers, no difference in bleeding. So important not to overinterpret. But I think the conclusion they reached, in my opinion, was safe, that using argatroban assay significantly reduced argatroban drug concentration requirements, infusion requirements. And it's intuitive to think that bleeding risk may be associated with increasing dose. And they did that, were able to show this without any increase in thrombotic events. So in my opinion, that's at least some evidence that the monitoring by the assay should be preferred. So, and again, Dr. Lester mentioned this, but one of the issues, we don't have argatroban assays widely available enough at this moment in time. This is a recent NEQUAS exercise, June 2021. 23 labs responded. There will be others doing the assay who didn't come back to us. We sent out 2 spike samples, normal plasma with added drug, and we had 2 pools of samples from patients, recognizing that spiked samples may sometimes behave in a different way. And there was a normal subject with no drug on board. And so these are the results in the different centers. So the green columns are all the results on one of the samples, the sample with the highest concentration. And you can see they're more or less in agreement, 1.1 up to maybe 1.5. So I think acceptable agreement between assays done in different centers. Many of these were using this dilute thrombin time assay, hemosil assay. We've got centres using hemoclot, also pretty widely used, and results were similar according to the different assays, and also you can see some SCAGO, echoing clotting time based assays. So different assays, same answers more or less. CVs between centres 9, 10, 11, 12, 13%, perfectly acceptable for routine use in my opinion. So it is out there in some centres. As an aside, of course, the increased use recently in VIC cases also involved careful monitoring of the coagulation parameters in those cases, fibrinogen included amongst those. Low fibrinogen is one of the problems in VIC cases. So just to remind ourselves that our main fibrinogen assay, Klaus fibrinogen assay, uses thrombin. There are different concentrations in use. If we look first at the lab method using the higher concentration here, this is a normal sample. This is centers using a lower thrombin concentration in the lab reagents. So more or less the same answer in normal. These were two different patient samples, pools of patient samples with argatroban concentrations in the middle of the therapeutic range here and a little bit above what might be the top limit just here. So here with the higher thrombin concentration, this is probably the accurate answer. But when we reduce the thrombin concentration, the kits that use lower levels, remember that argatroban is a direct inhibitor of thrombin, and therefore of the thrombin here in the lab reagent, we've got interference. We lose some of the thrombin, it prolongs the clotting time in the assay, and after the calculation, we come up with a falsely low result, about 10% of what it should be, a gross underestimation here, also at this level. The two samples here on the right, normal plasma, the same normal plasma spiked with a couple of different concentrations. So the correct fibrinogen level around here, here at 0.6, so low end, let's say the therapeutic range, we've got interference, we're underestimating, and there's a drug dependent effect, higher level of drug, more underestimation. So just to be aware, we should not use this thrombin assay or these with this low concentration to measure fibrinogen in the presence of argatroban. We need the higher version, and they're widely available. I mentioned that the assay is not widely available in different centres. We know that APTT in most of its settings is unstable in whole blood samples over time. What about argatroban concentration? So this is also some data that Susan in my lab ran, and these are some argatroban assays. You can see the concentrations here, so above the therapeutic range here and down and inside here and a little bit below. Sample whole blood, spun, processed, assayed straight away within the first hour. Store the whole blood at 24 hours as though it were being transported from another site, for example, and there's no difference. We've got a little bit, let's say, difference in the odd sample, but this is simply the precision of the test. So on average, no difference. It's stable, argatroban assay. So it's perfectly acceptable to send a sample along up the road to another centre who's got it available. I think that's something which we'll get used to doing more of in the future of centralisation. So what about fondaparinux? Just a couple of slides. I absolutely agree with Will's comment. It's not routinely monitored. We don't need to be measuring this very often. What if we do? Well, this is some guidance from BCSH a few years ago now, 2014, but still applies. Use an anti-10A assay, as Will mentioned. Fondaparinux should be used as the calibrator. We don't have an international reference preparation for fondaparinux. So does that introduce a little bit of additional variability? I'll show you some between lab data in the next slide. Just before we get to that, what kind of levels are we looking at if we do want to make a measurement? And that's shown at the bottom here for the, let's say, the treatment dose. So you're in this kind of area, 1 to 1.3 milligrams per litre. So target might be somewhere 1, 1.4, 1.5, that kind of thing. Again, don't need to do it very often. These are fondaparinux measurements by anti-10A assay. You can see the methods here. In a recent EQUAS exercise, and even though there were different lot numbers of fondaparinux, the drug used to calibrate the assay, despite that, pretty good agreement between these centres. So I think if we need to do the assay, it's pretty straightforward. I didn't bring any slides on tenaparoid, but the same would apply. Anti-10A assay, calibrate with the drug. And of course, then we're compelled to use the drug that's available for patient treatment. But even so, I didn't bring the data, but there's reasonable agreement if you're running that assay with different lot numbers of drug as calibrated. So same, can be done, not a problem. Okay, so a few changing tack now, since I think the title was monitoring non-heparin anticoagulants. So warfarin is not going away. We will have it for many years to come. So just a couple of comments on this. This is if you can read it, I'm not sure, 2016. And actually, it's just come back in the news recently. I think the law case must be in the American courts just now. Theranos, venture capital company, set up by people who did not understand lab tests and made a complete shambles. What this article, Neuroscientific Journal, in the newspaper, what it mentioned was the people in the Theranos labs ignored red flag quality control samples results, ignored QC results out of range. 80% of the QC results were out of range, and they did nothing. They carried on with the testing. It's absolutely astonishing. And this included INRs performed for monitoring warfarin. And it was so bad, in the end, this is an astonishing statement to me, the laboratory voided all INRs run on their local devices for a 12-month period, a year's worth of INRs. They just said, forget them, they're all wrong. They should lock the people up, throw away the key. Absolutely astonishing. So it can go badly wrong. So I think it's important to just think a little bit about INR. I'm going to insult your intelligence, but just to remind ourselves, when we're calculating INR, we measure the patient sample, the test prothrombin time. We do that in the lab. We decide what is the mean normal prothrombin time, the average normal value. We do that experimentally. So we measure this, we measure this. But then we have to apply this correction factor, this calibration factor, international sensitivity index. It's applied to this ratio to convert the test into INR. The ISI comes from this kind of exercise. It's done experimentally. We've got an international reference preparation here, and we've got a thromboplastin to measure the INR that's being calibrated. Series of normal samples, series of patient samples, 60 here, 20 here, and we fit a line through, and the ISI, International Sensitivity Index, is the slope of this line multiplied by whatever is the ISI of the international standard. So I just want to remind ourselves of that before I come to a fairly recent problem, let's say. And I think the issue we still have, and the one that causes us problems from time to time, is when an INR is measured by two different systems. It's not commonly done in the lab, but I think is occurring these days when a lab method is compared to a point of care system. And I'll come back to that point in a moment. What are the causes of differences between INRs? Well, it can be systematic, so it's there in every sample. That's what we should be able to avoid. It can be specific situations. I'll show you some examples. Maybe individual cases with particular properties. For example, I'll show you an example of a anticoagulant causing an issue. So thinking about point of care versus lab results, I think because of the major expansion in use of point of care INRs over the last 10, 15 years, it's often the case that a patient will move from primary to secondary care, particularly if a primary care site is running point of care. There may be concerns when a patient is over anticoagulated, the INR is elevated, and it is practice in a number of locations to check the high INRs, I suppose, because of the problems that would come if it were for a reason inaccurate. I'm not sure about that. I have to say that I like the guidance that we've got from BCSH that says if your INR is elevated by the system you've used, point of care or lab, if it's elevated, check it again by the same system. That excludes some kind of analytical error, pre-analytical error, and so on. Check that it's real by that method, and then proceed with the management. Don't do a cross-check with another method. And the reason it says that is because this is the kind of pattern you get. This is one point of care method, one lab method. You don't get a consistent relationship when the patients are over anticoagulated. Sometimes the highest result is here, sometimes it's here. you can see some differences, but of course, we just have to remind ourselves, we shouldn't be managing the INR, we should be managing the patient. And these results would all be the same management decision. If the patient has symptoms, then treatment's required. If the patient doesn't, it's simply reduce the dose. The problem comes if the difference occurs and is picked up and straddles a decision limit, then I think there can be an issue. And that's the kind of thing that led to this field safety notice back in 2018, so it's best part of 3 years ago, but I think it caused many of us some issues. And what happened was some centres noticed an altered pattern of results between point of care and lab method. Blackpool picked it up, Leeds picked it up, and they were centres who were checking INRs that were coming out greater than 8 on the point of care systems. That's their limit of reporting in most cases, and we're checking those against the lab. Totally reasonable to see what the result was in order to decide what is the management. As you know, the guidance is if result is greater than 8, then prophylactic vitamin K. If it's less than 8, manage the patient, no symptoms, don't need the vitamin K. So where they straddle that decision limit can cause a problem. And this field safety notice said, we've got a problem at elevated INRs. They went on to say that implied in this that the problem related to changing the calibration of their strips from this reference material, RTF09, that had been replaced by a new reference, RTF16. And the implication here was that caused the problem. And so they said, don't use these strips if they're calibrated against the old material, unless the INRs are less than 4.5. So is it really the reference material? Where does that fit in? So I don't want to go into great detail, but this is the sequence over the last 67 is 1967. So over many, many years, this is the sequence of human reference thromboplastins. We're currently on RTF16. And these are the ISIs that were assigned to these human reference thromboplastins. How were they done? In the kind of calibration I mentioned, but done for this material and for this against different international reference preparations, human and rabbit, and then an average. That's where this value came from. And what this table shows is that if a like versus like calibration had been performed, if the human was calibrated only against the previous human, this against this, this against this, if that had happened, this would have been the number, practically identical. But now, moving on, there's a small split up, 4 or 5%. And so there's been, let's say, a little bit of drift. So it's certainly possible that 3-4% of a difference could relate to the change from one reference to another. And that's kind of, let's say, the implication here. But it's only 3 or 4%. I don't believe this is the main cause of what happened. I don't think so. I think what happened is this. When you've got INRs up to 4.5, pretty good agreement between that particular point of care system here and lab methods such as Innovin, such as recombiplastin 2G, covers most of the UK. But here, where the INRs are elevated, you get a different pattern to the relationship. It's significantly longer here than might be the case here. And that's the relationship that shifted a little bit after a calibration of the point of care system. If we just remind ourselves, how is that done? We use outpatients, the company uses outpatients. It's restricted to this range of INRs. But of course, most patients have a target at the lower end. So it's not so easy to get samples at the top end, particularly when you're working on a point of care system and you've got to have recruited the patient to the calibration before you have any idea what is the INR. So I think this was also part of the problem. And what the company did, they did a 2-part calibration and therefore took account of this dog leg. And I think that what we're now seeing is much better agreement. Never be perfect, doesn't need to be. I think the agreement now is much, much better, and the sites who were noticing the problem, it's gone away. So I think we're back under control, let's say. I mentioned individual cases where we might see a discrepancy. So this is a case in my lab. Baseline INR, so before any anticoagulant, before any warfarin, grossly prolonged, normal by this method. These are two different lab methods. And as the patient's therapy over 3 days a week, 10 days, you can see the INR here with this method hugely prolonged compared to this. And this is a patient with lupus anticoagulant, strongly positive test for lupus anticoagulant, interfering here, not interfering here. It went away. It was when the patient needed surgery, and lupus anticoagulants of this nature can be transient. And so you can see a very good agreement here. It's gone. So for a while, it was necessary to monitor with this and not this. When you reach this point, we can use either. So final 2 or 3 slides, just a couple of comments, if I may, on direct oral anticoagulants. So not monitoring, as you know, there is no requirement for monitoring. And this is a comment from ISTH reminding us of this, because of course the trials didn't include monitoring, fixed doses and. So not required. But of course we are sometimes wanting to measure. So just a couple of comments if we want to measure. Be careful when the level of drug is really low. And of course, one of the settings where people have been interested to measure have been to confirm the drug has cleared prior to surgery. So at the moment, at least, I think that most of the methods that's routinely available would have a lower limit of
We seem to have lost Steve. Steve, you've muted yourself.
Ooh,
I wondered if you could very kindly wrap it up so that we've just got a few minutes left. We've got Will here as well. And I know people have got questions about fondaparinux and algatroban.
Okay, perfect. So I'll just show 2 more slides then, if I may. When we've got samples which don't have drug, this is a sample, sample 1 is a normal plasma, no drug present. People are reporting results as though drug was in the sample when it's not. So there's a problem, I think, with the lower limit that people have not understood. It's the same for rivaroxaban, it's the same for apixaban, it's the same for dabigatran. So summing up, I hope I've convinced you for algatroban, APTT, absolutely inadequate. Algatroban assays, simple, fast. Okay, we need them to be more widely available. Thank you for your attention.
Thank you very much. So we've had 2 fantastic talks, and I really want to pull back to the parental non-heparin anticoagulant. So we've got such clear messages here. Will, tell us a bit more about algatroban. I think it's the most amazing anticoagulant, and I think we should be using it more frequently, because once you've got someone stabilized on it, they usually remain in that area rather than going in and out of range as you do with heparin. And of course, it's not dependent on antithrombin levels, but the problem is it's so expensive. So how much algatroban are you using currently, Will?
Yeah, so we use it nearly exclusively on ITU just because it's there where you tend to need it. And I did mention about, using fondaparinux for breakthrough thrombosis on low molecular heparin, but we use algatroban on ITU for people who get breakthrough thrombosis on, say, IV heparin, say they're on a renal filter and they're clotting off their filter. On heparin, we'll switch them over to algatroban, and I agree it's much more stable than heparin. So you just normally you need to do a 2-hour assay and then another 2-hour assay, and generally you get in range, and then you can just do a once a day assay. And it's a nice drug to use. Our cardiac team get nervous using it for bypass because they're very familiar with heparin. But yeah, I think it is a good drug. And the other good thing about it is it's a reversible inhibitor of thrombin. So when we first used to use lepyridine, it was so bleedy, and it's irreversible. But because it's reversible, then it's much better to use. I mean, we did use bivalirudin a lot. I like bivalirudin as well. But algatroban's licensed, so it's yeah. So I agree. It's a nice drug, but we need every single major laboratory attached to ITUs having the right assay.
I agree. And Steve, have you noticed, you obviously have a feel for what's going on nationally, are more people moving over to better algatroban monitoring?
So it's increasing. I think the arrival of more use around the VIT story has focused thoughts on it.
Yes.
Good. So I think that the word is spreading. Certainly more and more assay labs are setting up the assay. Actually, it wasn't very clear on my slide. I should have said, and I've just seen one of the questions from Keith. So I should have said that the most commonly used assay is the dilute thrombin time assay. It's exactly the same reagents that work for dabigatran. So anybody who's got a dabigatran assay has got an argatroban assay, just with a different calibration. And there are commercial calibrators out there. It's not expensive when you consider the cost of the test versus the cost of the drug. I think it's really important that labs do that. And again, anybody who's in the 100 or so labs who've already got a dabigatran assay, it's a pretty short step to switch then into the argatroban. Okay, if you want to do it night and day, it's a little bit more tricky. But I think, as Will said, once you've got your patient in there and they're pretty stable, and the results don't need a huge amount of adjustment. And we've noticed that clinical colleagues aiming for a bit lower doses in some of the cases where they're a little bit worried about additional bleeding risk. I don't know whether you or Will wants to comment on that. Not my area, that bit.
Will, do you want to comment on that, on the levels you're aiming for?
Yeah, virtually all the patients we put on argatroban go on the sort of frailty regime, because by definition they're on ITU and they've generally got multi-organ failure, and it works pretty well, that regime. The whole VIT thing and whether we should give lower doses because people have had secondary bleeds is all, who knows? The main problem with VIT is obstruction by clot, and therefore giving lower dose of anticoagulation, we just don't know whether that's right or wrong.
Okay, can I move us over to fondaparinux? So we've got two questions. The first one is, if you're using full dose fondaparinux, are you using larger doses in those who are obese? Will?
Yeah, the SPC and the BNF gives you instructions on dose escalation. So I think it's 100, is it 100 kilograms, you go to 10 milligrams. I've actually used the sort of higher doses, like 10 milligrams, in people of normal weight if they've had breakthrough thrombosis. So there is the option to de-escalate and escalate fondaparinux, and it's generally pretty well tolerated, and I think the bleeding risks are quite reasonable. But yeah, there is a weight-based regime that you can follow.
Good. And then we come to the thromboprophylactic dose of 2.5, and I'm always sad that because of the cost of fondaparinux, it's about £6 an injection, we don't use it routinely in thromboprophylaxis in hospitals, because the normal cost of clexane is about £1 an injection. It's just too much to take on, and it's such a safer drug than low molecular weight heparin. There's a question in the chat asking about why we're using 2.5 milligrams in cardiac cases. Will, do you want to take that on?
That's in the context of PCI, and they're having sort of multiple antiplatelet agents at the same time, and it was used as a substitute for what historically was therapeutic low molecular weight heparin, with quite a high bleeding risk, actually. And what the OASIS studies, I think it was the OASIS studies, showed is that you could de-escalate the heparin equivalent dose and still achieve the same clinical outcomes. So basically it's a lower dose, but it's still in combination with antiplatelet agents after PCI seems to have a similar efficacy, and it's so much easier to give and so much safer. The only drawback was that there was slightly more thrombosis where they put in the catheters into the sort of arteries, and it's likely that pure anti-10A agents are just not so great for preventing thrombus associated with a foreign surface, essentially. So that was the only drawback of fondaparinux in the OASIS studies.
So nice guidance say to use fondaparinux because it's so cost effective. It's what, £6 compared with using full dose low molecular weight heparin, which might be 20. But some centres are still using low molecular weight heparin because of that risk, as you point out, of slightly increased rates of thrombosis. What are you doing in Birmingham?
Oh, we moved
in that setting?
Donkers years ago. And our guys are pretty conservative as well, so I'm amazed that people are still.
No, I'm afraid not everybody has. I speak to some of our cardiologists, but we get some very high risk patients. Okay, well, it's 1 minute past 12. I'm going to wrap it up. I'm going to say to Will and Steve, thank you for a fantastic session. You've really complemented each other. You've covered all areas. It's been absolutely amazing. So thank you both very much. And thanks to all the audience for listening in. If anyone's got any residual questions, I'm sure you can email us at Thrombosis UK. But thank you very much, and see you all again soon on one of the other Let's Talk Clots sessions.